the unexpected full thickness macular hole formation following intravitreal ranibizumab injection in RVO, a case series.
Hello everyone, I am Dr. Shobik Dan, and the topic is full thickness macular hole formation after intravitreal injection of ranibizumab and ranibizumab biosimilars in retinal vein occlusion, a case series. We all know anti-VEGF therapy, particularly ranibizumab, have shown efficacy to reducing the macular edema and improving the visual acuity in RVO patient. And the biosimilar agents actually offers a cost-effective alternative to the management of the retinal vein occlusion. There is a paucity of the literature regarding the potential unique complication, and full thickness macular hole after the anti-VEGF therapy is a occasionally reported complication whose pathogenesis is remain poorly understood. Aims and objectives are to discuss the potential pathophysiological mechanism, highlight the importance of the patient selection, consider the implication of, for clinical practices, necessity for careful monitoring of the patient receiving anti-VEGF therapy, and provides the insight into management of this rare complication. Methods. The series actually involving 5 patients who are with RVO are developed full thickness macular hole subsequent to the injection of the ranibizumab and its biosimilars. Actually, the cases highlights the varying presentation, management strategies, and outcome. And the treatment approaches are actually observation, pars plana vitrectomy with internal limiting peeling, and gas or silicone oil tamponade and intravitreal DEX implant. Studies site Dishai Hospital, Barakpur. Study duration 4 weeks to 4 months, and ages are actually 59 to 72 years age, male-female ratio 2:3, and primary outcome measure BCVA. These are the case summaries. Case 1, it is a 67 years female, base corrected visual acuity 6/18, presented with a hemi-CRVO. I injected ranibizumab biosimilars, and after 4 weeks, the patient developed full thickness macular hole. The primary management were vitrectomy, internal limiting membrane peeling, and followed by SF6 injection. The hole was closed after the primary surgery, but the CME doesn't resolve. So I implant one dexamethasone implant, and followed by another dexamethasone implant after 4 months, because the CME is not reducing, and ultimately the patient improved the visual acuity 6/9. Second case, it is a 72 years male, 6/18, present with BRVO, received 2 ranibizumab. After 3 months, same type of presentation and same type of management was given. And the third case, it is a case of CRVO. Here he's actually injected 2 ranibizumab biosimilars. After 80 weeks, the full thickness macular hole developed, and here we inject 1 dexamethasone implant. The fourth case, actually spontaneous closure happened because the hole is too much small. And the last case, we need to inject the silicone oil tamponade to close the macular hole surgery. This is some pictures of the cases. You can see some amount of VMT and CME in cases, and after injecting ranibizumab, there is a full thickness macular hole, and is after the surgery. So discussion part, intravitreal injection of ranibizumab actually inhibits the anti-VEGF the protein induces vascular permeability and angiogenesis, thus playing a pivotal role. Biosimilars are actually subtle differences in post-translational modifications occur, and they actually theoretically influences their safety profile. Rigorous post-marketing surveillance and reporting to detect the rare adverse event, and the full thickness macular hole formation is rare but a serious event. So the pathophysiological mechanism not entirely clear. There is 3 mechanisms: sudden release of the vitreomacular traction secondary to the rapid resolution of the macular edema, some mechanical damage by injection, and some inflammatory mediators leading to the tractional force to the macula. Discussion, there is a paucity of the literature, as already said, and actually the mainstream of treatment is PPV, and spontaneous resolutions are rare. Actually the prognosis depend on the chronicity of the hole, size and stage of the hole, presence of any concurrent ocular pathology, and the timing of surgical intervention. So conclusion, full thickness macular formation is a rare but serious complication, require prompt recognition and appropriate management. And further research, including post-marketing surveillance, is necessary to illustrate the full spectrum of the safety and efficacy of the biosimilars. As the use of the anti-VEGF therapy continue to expand, ongoing surveillance and reporting in better understanding and managing these complex cases. These are the references. Thank you.
So what is the pathomechanism behind the injection and macular hole?
Sir, I think some amount of vitreomacular traction is present in all cases. That should have been
Aggravation?
considered.
Aggravation of that traction is the cause for hole formation?
There is a sudden release of the traction when the reduction of the cystoid macular edema that can cause the hole formation.
How do you prevent that?
Sir, actually, we should actually do something else like subtenon Kenagot injection or dexamethasone implant in such cases.
That is your recommendation of this study.
You mean to say that the biosimilars have a more rapider resolution of fluid and thereby change in tractional lines as compared to the innovator?
I don't know actually, sir, but that may be the reason.
No, when the edema reduces,
Yeah.
will the traction not reduce?
Traction is always reduced. Because of the traction, the macular hole was formed. And after the internal limiting membrane peeling, there was some edema. I was injected Dex implant to reduce that edema.
You have not mentioned what was the pre-operative, the macular edema, how much was the thickness of the retina, whether it was ischemic, non-ischemic, and third thing is whether the PVD was present when you did the macular hole surgery, whether the PVD was there or no. So these three things I think are important.
Okay,